Hello everyone, Professor Baig here. This lecture is an overview of the gastrointestinal system. It basically covers the structure and function and a few other things, and it's supposed to be a review of the anatomy and physiology of it. And after this, we will cover the pathologies related to the GI system, and that will be covered in 3 lectures, one for upper GI, one for liver and pancreas, and then finally for lower GI system. Here are the learning objectives for this lesson. Let's talk about the structure and function briefly of the GI system. Sorry. So the component of the GI tract, you have the upper GI tract, which is your mouth, pharynx, esophagus, and your stomach. Then you have the lower GI tract, which is your intestines, your rectum, and your anus. And then you have accessory organs that also help with the GI system. Basically, your salivary glands, your liver, gallbladder, and your pancreas. Now, let's take a closer look at the architecture of the digestive tract, right? It's very complex and beautiful, right? While each organ has its own unique shape, the wall of the gut consistently has 5 continuous layers that work together to process food and protect the body. Now, starting from the innermost layer, we have the inner mucosa. This layer is extremely important because it contains the mucus protecting cells. This mucus serves 2 main purposes. First, it protects the delicate wall, of the tissues from harsh digestive juices, and it provides a slippery surface to facilitate the passage of the contents, right? Like after you eat a bolus of food, that bolus has to pass through your, intestines, and that's what the mucus helps with. It creates a slippery surface. Now, because of this, the constant wear and tear from food moving through, the epithelial cells in this layer, they have an incredibly rapid turnover rate, right? And they constantly renew themselves. This helps to maintain that healthy barrier. Now, just beneath the mucosa is the submucosal layer. Think of this as the supply and control center for the wall, the inner wall, right? It is composed of connective tissue. It's densely packed with blood cells, so you can get that blood flow there, the nerves to get those signals there, the lymphatics to help clean out the system, and the secretory glands. Right? This layer ensures that the gut has the blood flow, neural signaling necessary to function during a meal. Now next, let's move on to the engine of the gut wall, the muscle layers. First is the circular smooth muscle, followed by the longitudinal smooth muscle. Now these 2 layers are the primary drivers of motility and transport. What is motility? Movement, right? Now by contracting and in coordination, they have to contract in coordination. They create waves of peristalsis, right? The peristalsis is the movement of the bolus. This helps to push food through the system and the churning motions that help break it down. Finally, is that we have the outermost layer. This is known as the outer serosa or the visceral peritoneum. Now, this thin protective membrane, it encases the organs and it is part of the larger peritoneal system, which helps suspend and support the digestive tract within the abdominal cavity. Because remember, every organ in your body has a sac, like a peritoneal covering to it that helps keep it together intact, right? So that is the outer serosa for the gut. Now that we've talked about the layers of the gut wall, let's look at the envelope, we call it, right? That holds everything together, the peritoneum, right? The peritoneal sac. So this large serous membrane has 2 layers. The parietal peritoneum lines the abdominal wall, while the visceral peritoneum, it encases the organs themselves, all the organs of the GI system. Now, between these layers lies the peritoneal cavity, a potential space, basically, that normally has only like a small amount of serous fluid. This fluid acts as a lubricant, right? Allowing the stomach and the intestines to move against one another during digestion without friction or damage. Because remember, there's a lot of movement going on, right? The bolus, the peristalsis. And so this is what that helps with. Now notice the mesentery. This specialized double layer of the peritoneum, it attaches to the duodenum and the ileum to the posterior abdominal wall. It provides structural support and it prevents the intestines from tangling while maintaining the flexibility during peristalsis. Because you don't want them tangled, right? You want them to move, the peristalsis to happen without these thin layers tangling into one another. The mesentery also serves as a pathway for the blood vessels and nerves supplying the intestinal wall. So hanging from the stomach is the greater omentum. We often call that a fatty apron, right? Beyond providing insulation, it basically contains a lot of lymph nodes and it plays a very important role in in immunity. Now, when inflammation occurs, the greater omentum can migrate to the affected area and attach to it, adhere to it. And it helps the wall, like it's helping, ward off any infection and it limits the spread throughout the abdominal cavity, right? So it's basically acting as a immune protect, like for protection, immune protection. Finally, not all organs are enclosed within the peritoneum. The retroperitoneal organs, and which ones are these? These are the kidneys and the pancreas. They lie behind the parietal peritoneum. Now, these organs are covered by the peritoneum only on their anterior, the front part of it, the front surfaces, and are positioned securely against the posterior abdominal wall. And you can see all of this in these pictures. You have the peritoneum, you have the mesentery, the greater omentum, the lesser omentum, then you have the retroperitoneal organs. What is the function of the digestive system? I mean, obviously, it has all these complex, different, organs and, layers and all of that. What is the function of it? Why do we need that, right? First of all, ingestion is basically eating, right? Entry of the food into the GI tract. Secretion, it releases digestive enzymes, mucus, bile, and hormones. Motility, movement of the food through the GI tract. Remember the peristalsis? Digestion, mechanical and chemical breakdown of the food. Absorption, transfer of the nutrients into the circulation. And then finally, elimination. That is removal of indigestible waste. So that was the structure and the function of the GI system. Now let's move on to the neural and hormonal controls of the GI system, because remember your entire body, has hormonal and neural controls. And let's focus on the GI tract. The GI tract has its own nervous system. This is called the enteric nervous system, or ENS. It's often referred to the brain of the gut, right? The ENS contains more than 100 million neurons, and it can regulate many digestive functions independently, right? Controls that. Its primary responsibilities include controlling motility, secretion, and blood flow, which all are very, very important. And it does this throughout the GI tract. Now, within the ENS, there are two major nerve networks or plexuses. The myenteric plexus primarily controls peristalsis and smooth muscle contraction, right, which helps the food move through the GI tract. Then you have the submucosal plexus, which regulates secretion and absorption. This ensures that all the digestive enzymes, mucus, and nutrients are appropriately managed. See, like each one has its own function. Now, the digestive system is also influenced by the autonomic nervous system. I mean, we hear a lot about the autonomic nervous system, the way it works in the body, which then includes the parasympathetic, nervous system, what is the parasympathetic nervous system? This is called your rest and digest system. This stimulates digestion by increasing motility and secretions and blood flow to the GI organs. The vagus nerve is the major parasympathetic nerve supplying most of the GI tract. In contrast, you have the sympathetic nervous system, which slows digestive activity. And this happens during periods of stress, right? For example, if you are being chased by a lion, you're not going to think about, oh, I want to eat a bowl full of French fries, or you're not going to take a break and say, okay, let me eat, right? Obviously, you're under stress, so that's your flight or fight, right? So now the GI system can slow down because you don't need that right then, right? So this decreases the motility, it reduces secretions, and causes vasoconstriction. This limits blood flow to the digestive organs because now you're not using the digestive organs. You're not sitting down and eating, you're running away from a lion. So you don't need that blood flow there. Your body will use it elsewhere. Now, this response helps redirect the body's resources towards managing that stress rather than the digestion, right? You see how amazing, like extremely intelligent our body is. Now, to understand how the body manages digestion, let's look at the autonomic nervous system, right? It functions like a balancing scale, right? It has basically two sides, the parasympathetic nervous system, the PNS, which is the gas pedal. Think of it as the gas pedal, right? Okay, let's speed it up. And then PNS is then the sympathetic nervous system, the SNS, called the brake. Now together, they regulate digestive activity based on the body's needs. Now this is in relation to the digestive system. So basically the PNS, as we said, known as the rest and digest system, because it stimulates digestive activity. In the GI tract, it acts primarily through the vagus nerve, we said, the cranial nerve X. When activated, it increases motility, peristalsis, digestive secretions needed to break down the food. The PNS can be activated or triggered even before food enters the mouth. And how does that happen? So during the cephalic phase, the sight, smell, or even thought of food stimulates the digestive secretions, right? You smell something and you're like, "Ooh, that smells good. That makes me hungry." Or you see something like the Food Network, you're watching somebody cook something really good on TV and you're like, "Oh, that makes me hungry," right? So that's your cephalic phase. Just that can stimulate it, right? And cranial nerves, 7, the facial one, and 9, the glossopharyngeal, they maintain saliva production for speech and swallowing. So now as the food stretches the stomach, now you eat the food, as the food stretches the stomach or raises its pH, the PNS further increases the peristalsis and the secretions. It also supports elimination. How? Through the stimulation of the colon contractions and relaxing the internal anal sphincter. So your bowels can leave the body, right? So the sympathetic nervous system, basically the body's fight or flight response during stress, fear, or anger, it shifts energy towards the muscles and the heart and reduces digestive activity. So the CNS inhibits GI function and causes vasoconstriction. And like we said, it reduces blood flow to the gut. Now, this can sound a little confusing because the sympathetic nervous system will trigger a response, the fight or flight response in other parts of the body. Because remember, now we're talking about the PNS and the, SNS relate to the gut, right? So it does the opposite in the gut. So the sympathetic nervous system basically becomes, the rest and digest one. And then the other one, the SNS, the parasympathetic nervous system, the PNS becomes the gas pedal for the digestive system, right? Because that's what we're talking about. Now, excessive SNS activity reduces digestive secretions and slows regeneration of epithelial cells in the gut lining. As a result, what happens? Chronic stress, basically, can impair mucosal healing and increases the risk of lesions because the body remains in a catabolic or breaking down state. So think of a patient who is immobile, laying in the bed, right? And sick. Their body's under chronic stress, right? And so it basically, slows down the healing and causes lesions inside their gut. Now, to summarize, basically, to wrap it up, the penis uses the vagus nerve to increase motility secretions when food is anticipated or consumed, and the SNS decreases motility and secretions during times of stress. While the PNS supports normal digestive blood flow, the SNS causes vasoconstriction, which directs the blood flow to other organs that need it in a stress response. Now, while the nervous system provides rapid control, the digestive hormones act as chemical messengers that coordinate digestive activities throughout the GI tract. Because remember, we said hormones are what? Chemical messengers, right? When we covered the endocrine system in the endocrine lecture, I mentioned that, these are your chemical messenger. They pass messages throughout your body to make things happen. So now let's begin with gastrin. This is one of the hormones which is produced by the G cells in the stomach. When it's released, gastrin is released, when food enters and stretches, food enters and it stretches the stomach. Its primary functions are to stimulate gastric acid production and increase gastric motility. Now, this helps the stomach begin the digestive process because when the stretching happens, the process starts. Next, is secretin, which is produced by the duodenum. When the acidic chyme enters from the stomach, now it leaves the stomach into the duodenum, this secretin stimulates the pancreas to release bicarbonate-rich secretions. This helps to neutralize the stomach acid because remember, the stomach acid is very low in pH and very acidic. And so now the duodenum is not, it cannot handle that. And so what happens? The secretin basically causes your pancreas to release bicarbonate, rich secretions. So when it does that, it neutralizes that acid as it goes into the duodenum. This protects the lining and it creates the optimal environment for the digestive enzymes to function. Another important hormone is the cholecystokinin, or CCK. CCK is released when fats enter the small intestines. This stimulates gallbladder contraction. You see how systematically this works, right? And so when the gallbladder contracts, this causes bile to be released and promotes pancreatic enzyme secretion. CCK also slows gastric emptying, giving the small intestine adequate time to digest and absorb the nutrients. It's because you don't want it to go too fast, right? The hormone ghrelin, often called a hunger hormone, is produced primarily in the stomach. Ghrelin levels rise when the stomach is empty, and they stimulate appetite, signaling to the brain, hey, it's time to eat. So when your stomach is empty, you feel hungry, that's your, blame the ghrelin for that. In contrast, peptide YY promotes satiety, feel satiated, or the feeling of fullness. This is released from the intestines after the meal, and it helps to reduce appetite. Like basically tells you, okay, stop eating, let me digest this first, okay? Don't stop eating. This signals that sufficient nutrients have been consumed. Now together, these hormones help coordinate digestion by regulating appetite, stomach activity, pancreatic secretions, bile release, and nutrient processing. They ensure that digestion occurs efficiently and that the body maintains proper energy balance. So that was, hormonal and neural control. So now let's talk about digestion and absorption. Okay, let's talk about that process. So once we consume food, our body has to perform a complex series of chemical reactions to break down large complex molecules into simple ones that can actually be absorbed into the blood and transported to the liver. So now this process is specialized for each type of nutrient, right? You have carbohydrates, you have proteins, and you have lipids. So let's start with carbohydrates. Digestion actually begins the moment food enters your mouth, right? Or you look at food or you see food. So now saliva contains the enzyme, salivary amylase. And what does this do? This breaks down complex starches into simpler desaturates. As the food moves into the small intestine, the process continues with pancreatic amylase and specific intestinal enzymes, sucrase, maltase, and lactase. Now, these finalize the breakdown into monosaccharides, or simple sugars. Now, absorption then happens in the intestine. Glucose and galactose are absorbed through the co-transport system with sodium in an active process that requires cellular energy, ATP, remember? Fructose, on the other hand, is actually absorbed more simply through facilitated diffusion. See, a lot of these concepts that we covered in the first three lectures, the foundational lectures, those those concepts really help to understand this entire, each body system and the pathologies related to it. So now next we have proteins. Unlike carbs, their chemical digestion doesn't start until they reach the stomach, right? Because remember, with carbs, it starts in the mouth, right? Over here, proteins start in the stomach. Here, the enzyme pepsin initiates the splitting of long protein chains into shorter fragments called peptides. Now, when these peptides enter the small intestine, they meet pancreatic enzymes like trypsin and chymotrypsin, along with intestinal peptidases, we call them. These enzymes further break these peptides down into small individual amino acids. Much like the glucose, these amino acids are absorbed into the body through a sodium cotransport system. So now let's finally look at lipids or fats. Right? These are primarily triglycerides. Okay, this is a two-step process on the small intestine. In the small intestine, I'm sorry. First, the fats have to be emulsified or dispersed into tiny droplets by the bile produced by the liver. Once emulsified, these pancreatic and intestinal lipases can effectively act on the fat to break it down into monoglycerides and free fatty acids. Now, because these molecules are lipid soluble, they can diffuse across the cell membrane because remember they're lipids, right? They can diffuse easily because they're heavy, they're proteins. So they basically diffuse into the cell membranes of the intestinal wall. Now, once inside, they recombine to form chylomicrons, which enter the lacteals, the specialized lymphatic capillaries in the intestinal villi. And these eventually reach general circulation because remember, in order to pass through those cell membranes and, diffuse across those, they have to be, you know, fatty, right? They have to be fat soluble. Okay, and so let's move on and let's talk about common manifestations of digestive system disorders. So now we basically covered, the brief anatomy and physiology of the digestive system, neural and hormonal controls of digestive system, digestion and absorption. Now, how do we know when something is wrong, right? I mean, all of us, we don't have X-ray vision, right? That we can just look right through somebody and look at their digestive system, right? So how do we know? What are the manifestations that we see when something is going wrong in this process? Very complex, intricate process. So let's start with anorexia, nausea, and vomiting. When we look at digestive system disorders, three signs frequently appear together: anorexia, nausea, vomiting. Okay. These aren't just local stomach issues, right? These are very complex responses, and they're coordinated by sophisticated interplay between the brain and the digestive tract's nervous system, the ENS, right? So because remember the chemical messengers, the nervous system, so all of this that's why sometimes it's called a neurological problem, like the vomiting, dysphagia, things like that. Okay, so understanding these manifestations is extremely important because they can indicate problems with the GI tract or systemic conditions somewhere else in the body. Now, for example, like infection or kidney failure. So let's first define anorexia. This simply is the loss of appetite. Okay, it often serves as a warning sign preceding like more intense symptoms like nausea and vomiting. Now, nausea is subjective. It's a subjective and unpleasant feeling, right? I mean, somebody can tell you they feel nauseated, but you can't see them nauseated, right? So this is the urge to basically vomit, just the urge. They haven't vomited yet. Now, this can be triggered by a variety of stimuli. This can include GI distension, right? Irritation or inflammation. Interestingly, it can also be sparked by external factors, like basically the process, factors that, processes of the brain. For example, unpleasant smells or strong emotional responses like fear. Like when you smell something really, like, really that's, smells really bad, you're like, oh, you're kind of nauseated, right? Now, vomiting or emesis, which is the medical term for it, this is basically forceful expulsion of chyme from the stomach and sometimes the small intestine, because remember, there's one pump, right? And literally one set of things from your mouth all the way to your rectum. So now when your stomach is distended, it's overfull, distended, full of gas, whatever is going on over there, whatever pathology is going on over there, you're going to have this forceful expulsion of the chyme, the acidity in the stomach and sometimes the small intestines because right it's not very low in your GI system, right? Now this is a very highly coordinated thing. It's managed by the vomiting center. And where is the vomiting center located? In the medulla of the brain. So this center can be activated by conditions like we mentioned, distension, in the digestive tract, motion sickness. Some people get nauseated when they're in a car or like in a cruise, and the movement causes them to feel nauseated. And this happens through the vestibular apparatus or chemical triggers like drugs and toxins that stimulate the chemoreceptor trigger zone. Sometimes some medication, you'll notice a lot of medications, their side effect is nausea. Now, the vomiting reflex is a protective mechanism for the body, right? It follows a specific sequence. It begins with taking a deep breath and closing the glottis to prevent the accidental aspiration of vomitus into the lungs, right? Because you don't want the vomitus to go in the lungs. You want it to come out, right? At the same time, the soft palate rises to seal off the nasal cavity. Do we want it to come out of our nose? No, right? I mean, we want it to come out of our mouth. Okay, then the gastroesophageal sphincter relaxes and the abdominal muscles contract forcefully. And this squeezes the stomach against the diaphragm. You see how beautifully it's coordinated, right? Now, finally, the reverse peristaltic waves in the proximal duodenum and the lower part of the stomach expel the contents upward and out. So it doesn't go in the lungs, it doesn't come out of your nose, it comes out of your mouth. Now, finally, we can learn a lot about the patient's condition by examining the characteristics of the vomitus. I know it sounds horrible, right? You got to look at the vomit, assess it, see how much it is, what it looks like, what's the color, what does it smell like. So hematemesis, it refers to what? Hemata emesis, right? Blood in the emesis. If it looks like coffee grounds, or brown granular material. Like if, in coffee grounds, after you make coffee, you see the grounds, the wet grounds. If it looks like that, that means it means blood protein has been partially digested by the stomach acid. So if the blood is bright red, basically indicates extensive bleeding, a lot of bleeding, right? A yellow or green color, basically the coffee ground emesis kind of indicates GI bleeds, right? Active bleeding, extensive bleeding. A yellow or green color usually indicates the presence of bile. Now that has moved from the duodenum, because remember it's in the duodenum, it's released there. It came up and it came out, and so that's where it came from. So you can tell, where it came from just by looking at it. A deep brown color, very concerning, okay? Because this means that it's coming from the lower intestines. And often it signifies intestinal an obstruction in your intestines, right? You don't want anything coming from the lower, GI system because that's not a good thing. Now let's talk about diarrhea and blood in the stool. Diarrhea is characterized by excessive frequency of stools. Typically they're loose or watery in consistency. Sometimes they can be chronic, sometimes acute, and sometimes they can be accompanied with symptoms like nausea, vomiting, and cramping pain. Now, even though, some severe prolonged diarrhea, sometimes can be common in some people, it's serious clinical concern because it can lead to dehydration, significant electrolyte imbalances, metabolic acidosis, and malnutrition. Now we can categorize diarrhea based on its underlying causes. Okay, so large volume diarrhea results from either increased secretions into the intestines or increased osmotic pressure within the intestinal contents. For example, in people with lactose intolerance, you have undigested lactose, which remains in the intestines. This increases osmotic pressure. Now, this causes the intestines to retain the water because now it's pulling the water into the, intestines rather than absorbing it. Now, the type of diarrhea is also related to this type of diarrhea normally is related to infections or short transit time where it's passing by really fast, right? So, and this limits reabsorption, because it's going so fast. Now, in contrast, small volume diarrhea frequently occurs in people with inflammatory bowel disease, which we're going to cover in the GI disorders lecture. So in IBD, inflammatory bowel disease, the stools could contain blood, mucus, pus, or often they're accompanied by urgency and abdominal cramps. Another specific type of steatorrhea, another type is steatorrhea or fatty diarrhea. Now these stools are bulky, greasy, and foul smelling, which are hallmark signs of malabsorption syndrome like celiac disease or cystic fibrosis, where fats are not properly digested or absorbed. The presence of the blood in the stool is a critical diagnostic tool for monitoring GI disease. It should not be there, right? Bottom line. We look for the three main types: frank blood, bright red blood found on the surface of the stool. It typically indicates lesions in the rectum or anal canal, right? Where, for example, the blood hasn't been digested or altered. Now, occult blood, this refers to small hidden amounts of blood. It's hidden, occult, right? That aren't visible to the eye, but they're detectable. You can detect them through stool tests, such as a Guaiac test, right? We basically take a sample of the stool, we put it on this card, then we put a solution on there, and if it turns a certain color, these days it's not very common. We usually send it to the lab. It's not a very common practice. We usually just send the sample to the lab. Now, this is often called by small bleeding ulcers in the stomach or small intestines, right? Which is not a good thing. Then you have melena. This is a dark, tarry stool, right? This results from significant bleeder higher up in the digestive tract. The dark color is caused by intestinal bacteria acting on the hemoglobin as it travels through the system, which makes the hemoglobin dark. So now let's talk about constipation. When does constipation occurs? Constipation occurs when bowel movements are infrequent and stools are small and hard, right? This happens when you have decreased peristalsis, which allows for increased, time for water reabsorption in the colon. So if a lot of water is reabsorbed, then it leaves the bowl of the feces dry and hard. Chronic constipation can cause a lot of complications, especially hemorrhoids and diverticulitis. And it's a very common and severe problem among our geriatric population too, because of the slow, peristalsis. Now, while we often think of vomiting and diarrhea as just uncomfortable symptoms, they're actually major disruptions in the body's internal recycling system. Every day, approximately 7,000 milliliters of water is secreted into the digestive tract. And almost all of it is normally reabsorbed because the body needs it, right? You need fluids to maintain, body functions. Now, when vomiting or diarrhea happen, this recycling process gets broken down because it's not getting absorbed. Now, this can lead to severe, significant shifts in fluid, electrolytes, and acid-base balances. The most immediate complication of this fluid loss is dehydration and hypovolemia. Yeah, right. And if you need to learn more about that, please go back and, watch the fluid and electrolyte lecture. Now, but when the body loses fluid through the gut, it attempts to compensate. And how does it do this? It basically shifts the fluid from the blood into the digestive tract, right? Because it needs fluid. Now, if this continues, even the fluid inside our cells, it begins to decrease. Now, we have to be especially vigilant, like with infants and the elderly, because they're unique, because of their unique fluid distribution and the fact that their kidneys cannot compensate for losses as quickly, they are at a higher risk for rapid life-threatening dehydration. Now, along with water, we lose what? Electrolytes, right? Both vomiting and diarrhea can cause significant loss of sodium because the digestive secretions are normally high in electrolytes. However, the key difference to remember is that diarrhea specifically leads to significant losses of which electrolyte? You guessed right, potassium, right? So monitoring these levels is crucial because electrolyte imbalances, they can lead to what? Severe impaired circulation, cellular dehydration throughout all the organs of the body. Now let's look at acid-base balances, how that these can change depending on the severity of the condition. Now in the early stages of vomiting, the body typically enters a state of metabolic alkalosis because you're getting rid of the acid, right? You're vomiting out the acid. Now this can happen because the stomach is losing the hydrochloric acid, remember, in the stomach. Now as the body loses these hydrogen ions, what happens? The serum bicarb levels increase. And this shifts the pH of the blood. Where would it be for alkalosis? Higher, right? So the pH will be higher because acidotic is lower and alkalotic is higher pH. Now, the situation changes if the condition worsens. If vomiting becomes severe or prolonged, the body shifts into metabolic acidosis. This happens because what? The buffer system. So after prolonged, it takes time for it to kick in, right? To start compensating. So now the bicarb ions found in the duodenal secretions are lost. Similarly, diarrhea causes metabolic acidosis because large amounts of bicarb are lost directly in the stool. So this happens, a severe stage, the accompanying dehydration can be even limiting, that can even limit the kidney's ability to respond to the acidosis and causing systemic failure. So this is a very serious condition. Fluid, electrolyte, and acid bases can affect our body significantly. Now let's talk about pain and malnutrition. So now when diagnosing digestive disorders, understanding the nature and location of the pain is a very important clinical tool, right? Because the gut is innervated by different parts of the nervous system. Patients will describe their discomfort in very specific ways depending on which tissues of the digestive system are involved. Now, today we're going to look at just two types of pain, visceral and somatic. And we're going to look at how chronic GI issues can lead to malnutrition. First, let's discuss visceral pain. These pain fibers are connected to the autonomic nervous system, which makes this type of pain notoriously difficult for patients to localize. Like they'll feel the pain, but they can't touch it and say, okay, it's here, The way the pain feels can often tell us exactly what is happening. So the way they describe it, basically. So burning sensation frequently associated with inflammation and ulceration in the upper GI tract. A dull aching pain in the upper right quadrant, typical of the liver capsule being stretched by swelling. Cramping or colicky pain usually indicates that the system is trying to force contents past an obstruction. So when you have an obstruction in the stomach, it's going past there and that causes cramping or colicky pain. And, because basically your body is trying to deal with severe inflammation in the intestines. Now, in contrast, somatic pain, this originates in the parietal peritoneum. Remember the lining of the abdominal cavity? This has a high density of pain receptors in it. Unlike visceral pain, somatic pain is steady, intense, and very well localized. Because these receptors are linked to the spinal nerves, they often cause a reflex spasm of the overlying abdominal muscle, which leads to a rigid or guarded abdomen, like you feel the tightness there, the rigidness, or, the guarded abdomen. People are guarding it, right? A hallmark sign of somatic involvement is rebound tenderness. This is often seen over an inflamed area like the appendix. Now let's talk about malnutrition. The long-term impact of malnutrition, disorders of the patient's nutritional status, can be a general deficit resulting from chronic anorexia, vomiting, or diarrhea. This prevents the body from absorbing the energy, the total energy it needs to supply to the body, right? Basically. However, we also see very specific nutritional deficiencies as well. For example, we'll see vitamin B12 deficiency. This can occur if the gastric mucosa fails to produce in the intrinsic factor, which is required for B12 absorption. So now if it's not absorbing the B12, the body's not absorbing the B12, then you're going to have a deficiency in it. Iron deficiency is a common complication from chronic blood loss, from condition like a bleeding peptic ulcer. Malabsorption syndromes, such as celiac disease, these can lead to wider, broader deficits because the intestinal villi are damaged and cannot process the nutrients effectively. So you're going to have a wide variety of nutrients that are going to be deficient. Okay, now let's look at common labs real quick and diagnostics. So, even though imaging studies and endoscopy allows us to visualize the structure of the GI tract, specialized functional tests also help us evaluate how well the GI system is actually performing its normal functions. So the first test over here is the ambulatory acid probe test. And then we have the, gastroesophageal reflux disease, which basically is used to diagnose GERD. During this procedure, a small pH probe is placed in the esophagus and it continuously measures acid, exposure over 24 to 48 hours. This allows providers to basically determine how often acid reflux occurs, how long each episode lasts, and whether those symptoms are correlated with acid exposure. The second test is the esophageal manometry. This basically measures the strength, coordination, and timing of the esophageal muscles during swallowing. Now, normally, coordinated peristaltic waves move food from the esophagus into the stomach, while the lower esophageal sphincter relaxes appropriately. The manometer helps to identify motility disorders that can cause dysphagia, chest pain, impaired transport of food. Then finally, we have the Rome criteria, which is used to diagnose irritable bowel syndrome or IBS. Unlike other digestive diseases, IBS does not cause visible structural abnormalities. Instead, the diagnosis is based on the characteristics, pattern of symptoms, including recurrent abdominal pain associated with changes in stool frequency or stool appearance. Before the diagnosis of IBS can be made, other infectious, inflammatory, metabolic disorders first, they get excluded. You have the differential diagnosis. These are all excluded before IBS is diagnosed. Now, all of these together, they give us a lot of important information about the GI function, and it helps diagnose these conditions, which may not be, detected through like other tests, like lab tests. These are the different labs that can be done and specialized tests that can be done. So basically we have the stool, specimens to detect for blood, things like that, blood samples to detect for infection, inflammation. Then we have the gastric washing. This can provide evidence of infection again. Then we have other samples, like tissue fluid samples, biopsy samples, things like that. And then, the basic labs are basically CBC, CMP, amylase and lipase, stool studies. And then other blood tests are liver function tests, because remember the liver and pancreas, all of that are part of your GI system. Then we have tumor markers and a celiac panel to diagnose celiac disease. These are specialized function tests, basically the ambulatory acid probe test, the esophageal manometry, and the Rome criteria. Let's briefly talk about treatments and pharmacology. When treating GI disorders, dietary adjustments and lifestyle modifications are the first line of defense. These changes are specifically tailored to the underlying pathophysiology of the disorder and can vary significantly depending on whether the goal is to remove a trigger, improve motility, or provide the bowel with necessary rest. Now, for people with celiac disease, a gluten-free diet is, is not just a suggestion, it actually has to happen. It's essential, right? And by removing the source of the problem, like grains like wheat, barley, rye, the toxic effect that it's causing on the intestinal villi is eliminated. And that helps with the problem, relieve the symptoms. This, basically allows the mucosa to heal, right? And usually, within a few weeks of strict adherence, people start seeing the difference. Now, fiber and fluid play, a dual role in GI health. Increased fiber and fluid intake are strongly recommended to treat and prevent chronic constipation and diverticular disease. Now, these help increase fecal bulk and promote regular intestinal motility because if the bulk is there, the intestines will work. Now, conversely, during acute exacerbations of inflammatory bowel disease, IBD, the strategy is going to change, right? You have low residue or low bulk diets. These are used specifically to reduce intestinal stimulation. We want to stop the stimulation. We want to ease it, ease the workload on the inflamed bowel. Now, for patients experiencing dumping syndrome, the timing of and size of meals, they're critical. This condition is managed by consuming small, frequent meals that are high in protein and low in simple carbohydrate fats to kind of slow it down so it doesn't, digest too fast. Now, this approach, like I said, helps with, prevents the rapid entry of the hyperosmolar chyme in the small intestine and helps stabilize blood glucose levels and prevents the sudden fluid shifts, which can lead to dizziness and sweating. To manage conditions like peptic ulcer disease and GERD, patients are advised to avoid specific triggers, reducing or basically eliminating the intake of alcohol and caffeine, and spicy foods also significantly promote the healing of ulcers, which reduces the acid reflux and causes the burning sensation in GERD. Now, finally, it's important to address the role of the nervous system. Stress reduction techniques are highly important and beneficial for disorders like IBS and IBD because psychological or physical stress, it stimulates what? The sympathetic nervous system. So when the CNS is overactive, it causes vasoconstriction in the gut, in the gut mucosa, basically inhibiting GI healing and can exacerbate inflammation, motility, and secretions. These are the different medications that are used to, GI disorders. You have antacids to neutralize acid, antiemetics, reduce vomiting, for motion sickness, drugs, radiation. You have acid reduction medications basically to decrease the secretion, block the secretion of hydrochloric acid. You have anti-inflammatories for, disorders like IBD, to help reduce, the inflammation. You have antimicrobials to treat any bacterial, protozoal, or parasitic infections. Then you have antidiarrheals. These reduce intestinal motility if the diarrhea is not relieved by diet. And they're not very, recommended a lot unless it's severe. Then you have laxatives. These increase the bulk, right? Intestinal motility for constipation. Then you have coating agents like sucralfate, we call it. And basically, they cover the ulcers to allow them to heal. It creates a covering over the ulcers. So as food is being digested, they don't irritate those ulcers and have a protection. Now, if none of those things work, then we have surgical and invasive procedures. You have resection and ostomy to help allow the stomach to heal. You have the paracentesis, basically when you have too much fluid, in the ascites, too much fluid in the stomach area, the peritoneal area, then paracentesis removes that. Then you have the laparoscopic surgery, and finally liver transplant. Biggest thing is prevention, right? Preventative measures. You have vaccinations, screening, and hygiene. And that is it for our lecture on the overview of the GI system. Following, there will be 3 other lectures, one on the upper GI, one on liver and pancreas, and finally, the one on the lower GI system disorders.